So thank you all for coming to this track, the Healthy Aging track. And today we are going to be talking about driving change, delivering results, proven solutions for better health. My name is Lenise Cummings Vaughn. I'm a geriatric physician, and I'm a medical officer in Quinvig, CSQ. And I'm really happy to be here with these esteemed speakers to talk about one of my favorite topics, the care of older adults, and more specifically, especially the framework that the age-friendly healthcare system has provided us with. So our presenters, number one is going to be Ronnie Snyder, who is the acting president of the John A. Hartford Foundation. She will be discussing the fundamentals of age-friendly health system care. Then we will have Dr. Timothy Farrell, who is coming to us from the University of Utah, and he will be talking about the University of Utah's experience with the age-friendly healthcare system implementation. Then we have Dr. Alice Bonner, who will be speaking about, we will actually have Dr. Gregory Alexander next, and we will be speaking about healthy aging through prevention and quality of care. He's coming to us from Columbia, and then Dr. Alice Bonner will be wrapping everything up and bringing it together. All right. So very briefly, I just wanted to say that I don't know, I hope that everybody's familiar, but if you're not, you will know about the age-friendly healthcare system by the end of all of this. This was an initiative that was developed by the Institute of Healthcare Improvement and the John A. Hartford Foundation. The goal of the initiative is to spread reliable and reproducible evaluations and interventions that have been shown to improve healthcare quality, safety, and effectiveness by reducing hospital readmissions, emergency department visits, limiting harm, preventing functional decline, and decreasing unwanted or unnecessary care. So Dr. Oz has been speaking about his OKRs, his 5 Cs, and the age-friendly healthcare system movement has the 4 Ms, which Ronnie will be speaking about. The 4 presenters will provide the background and the real-life examples of the implementation of these tenets of age-friendly healthcare. The return on investment for the initiative has affected health professionals, health systems, and most importantly, patients and their caregivers. Healthcare professionals in the initiative have reported increased knowledge and confidence in implementing the change after participating in action communities. Additional return on investment includes avoiding cost of poor quality of care, delivering care in cost-effective manners, and enhancing revenue from high-quality care. Reports from Hartford Hospital's Action for Delirium Assessment, Prevention, and Treatment Program integration of the initiative reduced the days of attributable delirium, decreased length of stay for delirium patients from 16 days to 10.6 days, and an average of $6.5 million in savings annually from 2012 to 2019, just for an example. So I'd like us to dive deeper into hearing more about the work and the examples of implementation of this wonderful care.
Thank you, Lenise. I love that you started with some of the evidence. You see how excited I am? All right. So I am Ronnie Snyder. I'm very excited to be here talking about the work that we do with a whole host of just fantastic partners. I'm going to talk about a solution that makes sense. That's age-friendly health systems. It's already being embraced by hospitals. And Lenise referenced hospitals, but I should add that it's not only hospitals. Age-friendly health systems is a framework that applies also to ambulatory clinics, convenient care clinics, PACE sites, FQHCs, and really importantly, nursing homes as well. So I'm going to be talking about that kind of age-friendly care as well as a new age-friendly hospital measure that CMS has recently enacted. I have no conflicts. Oh, I'm not moving forward. There we go. All right. So why? Why do we need age-friendly care? Well, the first and most obvious reason is simply demographics, the increasing number of older adults themselves that is rapidly growing. There's also the issue of complexity. So older people are more likely to have multiple chronic conditions, things like dementia, things like individual and sometimes overlapping disability. Social isolation can be a large issue for many older people. And then there's the disproportionate harm that too often will affect older adults. Now, that may be in part the result of the complexity mentioned here, but it's also an effect of simply needing more, a higher number of clinical visits, for example. It's also perhaps a result of just the changing physiology that we all experience as we age. So this is an opportunity, age-friendly care, for prevention, which is really important to CMS right now, and also for empowerment of older adults and their caregivers to take control of their own health. It's a ripe area for enhanced technology as well as data. And so these are all things that I feel like we're near the end of this conference. It's been a major topic of this conference. Okay. So as Lenise mentioned, the Institute for Healthcare Improvement, the John A. Hartford Foundation, the American Hospital Association, the Catholic Healthcare Association of America came together and thought through the framework of the evidence-based 4Ms. It really was intended to build an entire movement so that all care that any older person gets in any setting of care, we often say from the kitchen table out to a healthcare touch and back home again, is age-friendly. And what that means is that it is guided by an essential set of those evidence-based practices. That's what we call the 4Ms. And they're listed here. You can see the images. Top foremost is what matters to the older person and his or her caregivers. I'm not going to be speaking a lot about caregivers right now, but I will say that caregivers are a central tenet of the work that we do because they are the backbone of care for so many older people. So it applies in many of these different ways. The other three are medications, mentation, which is anything cognitive. It is dementia, delirium, depression, and mobility as well. Age-friendly care is really best care for anyone. It's just that it's more important for older adults than for many other people for all the reasons that I just mentioned on the last slide. Those 4Ms are designed to be used together. They're all connected, and they equal better, higher quality care that will cost less, that will get better outcomes, and that really ultimately support everyone at any age, and that includes support for caregivers as well. So it creates both an efficiency and a continuum of care because it's not just one care setting. Age-friendly health systems, the framework, the principles have now been embraced by over 5,000 sites in this country, many more in other countries actually. And it's growing very quickly. Really, every time I look at the numbers, they just increase by leaps and bounds. So this is real. This is happening now, and it's doing things like reducing length of stay, like reducing rehospitalizations, and like decreasing nursing home admissions, at the same time that in many cases it's increasing patient satisfaction. I do want to note that there is a research network at UCSF. There's strong evidence already on the outcomes for 4Ms age-friendly care. And there's a growing evidence base that is both about implementation and also on outcomes. And so we're pulling it all together through one research center at UCSF. The research center is guided by a council of leaders in age-friendly health systems with a broad representation across different settings and also different disciplines, because there's not a single discipline that is affected by this kind of work or that carries out this work. Members of the network themselves, there are now up to 487 of them, have a variety of opportunities around age-friendly health systems. So they include the ability to present, get feedback on ideas for research for age-friendly health systems, or measurement work, to share tools and resources across different sites and types of care. Those include funding opportunities potentially, learning about emergent topics around age-friendly health systems, and identifying potential collaborators. So you can see the link here if you're interested in being one of those people. There's also new funding for this network around the age-friendly hospital measure that I'm going to talk about next. And there are also opportunities to look, again, at tech and at infrastructure enhancements. Okay, there are a lot of ways to get involved. They are listed here. My colleague, Marcus Escobedo, he's got his hand up right there, has got a couple of one-pagers if you want more information afterwards. And you're going to hear about an exemplar from Tim next at Utah. You're also going to hear later about the Moving Forward Coalition, which we very proudly support, because nursing homes are a really important part of both healthcare systems and communities. Okay, I mentioned the age-friendly hospital measure. So this is a new measure, just began this year. Thank you to CMS for all the work that went into this, and Cliff Coe, who was presented in a previous session. This is really recognition of how critically important age-friendly health systems and its concepts are to best care for older people. I want to note there are 5 domains. I won't go into them in depth because Tim's going to talk a little bit more about them. But what I do want to do is point out in blue those 4 M's and where they're embedded in the 5 different domains of this measure. What matters there at the top. And the last bullet there, which doesn't have one of the M's, is nevertheless integrally tied to the age-friendly health systems work and implementation, because we have found over time that you really need those key leaders at a variety of levels within an institution to make this work. I want to give full credit to the measure developer, which has been led by Cliff Coe at the American College of Surgeons, and it builds on not only the age-friendly health systems work, but also the geriatric surgery verification that he leads, and some geriatrics emergency care accreditation that is led by others within our broader network. So this measure is really a signal that CMS fully understands the population health imperative to improve care for older people. It's going to drive increased improvements over time. And there's a true opportunity here because, again, I mentioned before, this isn't just about hospitals. The measure is a hospital measure, but really the field is going beyond the hospital measure and talking about what we need to evolve past only hospitals and really do this work in communities. This is my last slide, but it's really important, so I'm going to spend just a minute here. Hospitals are really, I'm focusing on hospitals here because of the measure. They're really embracing and going beyond the age-friendly measure itself. So there are a growing number of hospitals, we're at about 627 now, so we're a little over 10%, that are doing this work, that are recognized as participants. By the way, there are also about 880 nursing homes. There are also currently 30 different systems that have joined because they want to do a system-wide spread within each of their systems. So it's not just one hospital or it's not just one ambulatory site. They want to do it all throughout their system because they see the importance of this work. They've been highly engaged. It's been going on for about 15 months now, and they're spreading throughout all of their different locations. So I mentioned both surgery and ED, and those are your 3rd and 4th bullets here. So there are now 575 accredited emergency departments specific to geriatrics. There are also 78 hospitals that have geriatric surgery verification. This is really important because a lot of the sites that are looking to be able to respond to the new age-friendly hospital measure are going beyond just the checkbox in the current attestation measure. They're looking to really make sure that they are embedding in very meaningful ways. They're usually doing that by implementing one of these 3 programs, or 2, or in some cases, we've got about a dozen of them that have done all 3 programs within their hospital, which is pretty impressive. So I have some examples for you. Lenice gave us a great one on the front end. Cleveland Clinic has got some Geri ED work. They've got a new Geri ED program. They're using their EHR to automate screening for high-risk older adults in the ED. They're linking to a delirium screening tool, and by doing that, they're reducing avoidable readmissions by up to 73%. They're reducing length of stay, and they're showing savings of $2.8 million per year. Rochester Regional Health is also doing some of this work through the surgery verification program. They're showing reductions in postoperative complications, in patient days spent in the ICU, and also more patients are being safely discharged home rather than to a temporary skilled nursing facility. We have dozens and dozens of examples. I'm not going to list dozens and dozens, but I do have a couple more I'm going to share with you before I wrap. Northwell is listed here because they're one of the ones doing the system-wide spread work. They've included 4M's focused improvement initiatives as core components of their system. And they've got all 17 of their EDs now in the accreditation for geriatrics EDs. They've got 64 outpatient clinics that are using the EHR note template to address the 4Ms. So there are ways that systems are already of their own volition jumping in with both feet because of the importance of this topic. In addition, Owensboro, that's in Kentucky, has taken steps. This is really cool. They've taken steps to align senior leadership and C-suite compensation and performance incentives to age-friendly health systems achievement. At Grady Health System, which is in Atlanta, they've created nursing, employment, and leadership pathways that are very much aligned to the geriatric care that's offered through age-friendly health systems, and leveraged geriatrics-focused care as a recruitment and a retention tool, because we're seeing that it's improving satisfaction among clinicians as well. This checks a lot of boxes for CMS. In Houston, they have leveraged asking and acting on what matters to counter care team burnout. Back to the clinicians. So I'm going to stop with the examples there because I might have beaten that horse to death. But I do want to say in conclusion that age-friendly healthcare is our moral imperative. And that's not just because of the demographics, it's also because of the financial and the social implications of doing better in the care that we offer to older adults. It's already happening, as indicated. It's improving outcomes. And it really speaks to the continuum of care, not only hospitals. So the new age-friendly hospital measure is already being embraced in many, many different sites. And I'm going to read you a quick quote from Sutter Health, who reported to CMS to say that they unequivocally support the measure because it complements initiatives aimed at increasing system efficiency, decreasing unnecessary treatments, and fostering informed healthcare choices. And that, I think, is what we all want for our patients. Thank you.
Well, hello, and thank you to Dr. Ling for the opportunity to speak today. And I want to credit Ronnie for all the work she's done to really get us to where we are with age-friendly health systems. I'm reminded of a conversation I had with our former Senior Vice President of Health Sciences at University of Utah, who said age-friendly health systems is not only something that we have to do, but something that we should do. And I think that gets to the moral imperative that Ronnie was talking about. So let's take a little bit of a deeper dive into the University of Utah health experience implementing the CMS age-friendly hospital measure and preparing for that. So no conflicts of interest. Just some background about Utah. Like most states, we are aging, but we're now, I believe, the 5th most rapidly aging state in the country, even though we are still relatively young, demographically speaking. But we have about 1 in 9, 1 in 10 Utahns who are 65 plus. That's going to change to about 1 in 5 in the year 2050. So our entire university strategic plan now actually does include aging, which is pretty exciting that we're preparing that way. I've just sort of shown our age-friendly journey as sort of some context for the discussion. We started off in about 2018 when Dr. Terry Fulmer, who I'm sure many of you know, came out, and I think Dr. Supiano, my former division chief, arranged an extra half day for her to meet with our leadership, which was really the catalyst for getting age-friendly embedded very early in our system. Then we sort of went along the pathway towards level 1 participant designation from IHI and level 2. And I want to credit Dr. Supiano again for having the foresight to create my current position, Associate Chief for Age-Friendly Care. And just that title, having age-friendly my job title, has been hugely relevant for me in sort of making the case, because if it's in your job title, it must be important, right? So it's really been useful in my travels around our health system leadership. And I believe UAB, I want to credit UAB for, I think, being the first one to have that title. And then we had age-friendly care embedded in our health system strategy for this year, and kind of culminating in membership in the IHI System-Wide Spread Collaborative that Ronnie talked about earlier. So another point I want to make is, we're on this pathway, we've been doing a lot of age-friendly care, but we still have a lot to learn. Let me go back one. Okay. So just want to give you a sense of some of the age-friendly programs we have at our institution. I want to credit the Hospital Elder Life program. That program hits all of the M's, not just delirium and mentation, but it really was instrumental in getting us our age-friendly designation. We have a bronze-accredited geriatric ED. We do a lot of work with What Matters with patient priorities care. On medications, we have the American Geriatric Society Older Adult Vaccine Initiative. We've worked with the Open Notes team on gaining proxy access, especially for loved ones with cognitive impairment, making sure their proxy is able to see what's in the record and communicate. And as of yesterday, officially, we are one of the CMS guide model participants, which we're super excited about, because I think that's going to be, thank you, very, very, very important. I've learned a lot about taxpayer ID numbers in that journey. Okay, so I like to say I've read the Federal Register, so you don't have to. This is the age-friendly measure, and it's a little bit dense in terms of the text, but I think it's important to show for reference. And just to orient anyone who hasn't seen this, in the left-hand column, there are 5 attestation domains, okay, and Ronnie talked about those. I'll dive a little bit deeper. The first one, listing patient health care goals. This isn't simply saying, do you have an advance directive, right? This is actually doing a little more than that. I really like the specific item about identifying healthcare proxies. One of my interests is patients who have no decision maker. So, that is a hugely important demarcation point. Responsible medication management, looking at potentially inappropriate medications. A lot of people probably use Beers criteria for that, but I kind of like with IHI, it's not really prescriptive about which way you sort of get at this. It gives health systems a lot of latitude. Domain 3, I was talking with Dr. Koh earlier, I said, you put a lot into domain 3. So you've got delirium, you've got mobility, you've got nutritional assessment, malnutrition being some people would say the 5th or 6th M. You've got falls, decubitus ulcers, 30-day readmits. There was a session yesterday on ER throughput and sort of boarding. You've got to demonstrate that you can get people, older adults, through the ER in a timely fashion. Domain 4, social vulnerability. We've been spending a lot of time on this in our health system, sort of figuring out what we're screening for currently in terms of elder abuse, caregiving, financial insecurity. And then domain 5, I have a head start because I've got age-friendly in my job title, but you can have one person do this or a team do this. And it is super, super important to have those age-friendly champions. Also, this is an attestation measure. It's sort of pay for attestation. Hopefully I'm saying this right. I've got the CMS crew right here. But my understanding is that you can attest no on everything. If you're not meeting them, you don't lose money now, but you may in subsequent fiscal years. So the idea now is just to kind of get used to these domains, see what's there. You will, though, have to eventually attest to each of the domains and the subdomains to get full credit for the measure. Okay, I want to talk a little bit about kind of 3 major challenges we had. One was that our forums assessments were scattered about the EHR. So we had people doing, mini-cogs, and they would rename it something else for a research study. So there'd be 2 mini-cog flow sheets, and it was kind of confusing. We had inconsistent delirium screening. So just in our hospital, just screening in the ICU, but not in the inpatient wards. And also no capability to quantify the 4Ms. So let me talk about how we addressed those shortcomings. So we created something called the 4Ms Navigator. We surveyed our geriatricians, and they gave us the most common, useful 4Ms tools that they liked, and we kind of put them all into one place. And the beauty of this is that if you're opening up a Medicare annual wellness on the outpatient side, or if you're on the inpatient side, seeing a patient, it's sort of in Epic, it's in the workflow, so you don't have to go somewhere else, it's just right there. And then you capture this as discrete data that you can then query. Here you can see we highlighted the CAM, so you fill out the CAM, and it goes into actually another place in Epic where you get all the 4Ms kind of in one spot for one-stop shopping. So that's the 4Ms Navigator. Our second challenge, delirium screening. The IHI System-Wide Spread Collaborative was hugely helpful here because that was sort of the impetus to bring all the teams together. And for decades, we didn't have delirium screening done consistently, but when they saw the measure and saw the importance of delirium screening, how we can move the needle with the Elder Life program, our system stepped up and said, we really need to do that. The right care is to get everyone screened for delirium. So we have executive sponsorship, nurse quality, all of those essential pieces in our age-friendly leadership team. And I'll just sort of move towards wrapping up in a moment. The third challenge really was the 4Ms were sort of scattered across the electronic health record. So we had a paper last year that described how we overcame this challenge. We engaged with that age-friendly research network that Ronnie talked about with UCSF to find a way to sort of track the 4Ms in our system. Because of course in quality, if you can't measure it, you don't know what you're improving. So what we did is we took the UCSF approach and we shared our code in Epic. That's a longer story, but it's quite a little bit complex, but it's doable. And we came up with this thing called the M-level index. So if you look at a patient's journey throughout a hospitalization, we looked at it in terms of an encounter and the number of shifts. So let's say they were hospitalized for 3 days and they had 3 or 4 shifts per day, 12 shifts. That's the denominator. Those are all the opportunities to give 4Ms care. The numerator is how many times during those shifts was that 4Ms care provided. We did this for about 3 years with about 16,000 patients, 25,000 admissions. We look back at 300,000 nursing shifts almost. And what we found, we have a composite M-level index. We were able to say confidently, and we get a monthly report on this, that half of our patients are getting all 4Ms, which I guess, are you a half empty, half full kind of person? It's at least a good starting point. You'll notice we're doing better on some of those M's. Some medications, we have some automatic reminders of PIMS and things like that. What matters in mentation, though, are a bit more of a struggle. What matters information tends to be less discrete data and more sort of descriptive data. So what we're hoping is that this type of information can be presented in a dashboard. We're going to be able to present to our clinic leaders and our C-suite to get kind of that real-time data that CMS was talking about. Take the pulse of the health system. Where are we on the 4Ms and where do we need to deploy resources? This, I think, also aligns with CMS in terms of the learning health system. My colleague Jory Butler coined the term the age-friendly learning health system, where we take that 4Ms data and then immediately get that into a process improvement cycle. You can find this in the JAGS paper too. It's all freely available. So my next to last slide, I think, just sort of where we go from here, and beyond checking boxes. Ronnie already talked about health systems that are really taking this to the next level. And I think this is a floor, not a ceiling. So we want to do the dashboards. We want to use large language models to extract that, that qualitative what matters data, make it available to the people who need it, the hospitalist. So get that outpatient what matters data, get it to the inpatient side. We want to get this into education. I'm an educator at heart. We can't lose that. Okay, so let's use this as an opportunity for our medical students, residents, fellows, everyone, all disciplines to sort of understand why this is important and integrate it in their education. And lastly, when IHI came to our hospital, and also when our PFAC, age-friendly PFAC members told us, you got great age-friendly care, but we get it in one place. Like we get it very deeply in the geriatrics clinic, but if you go across the street to the other clinics, we don't have it. So let's get this horizontally integrated. I'm going to urge CMS to consider an outpatient age-friendly measure, and let's get this, let's get the inpatient, outpatient integrated together and incentivize all that great 4Ms care. Just want to shout out to our team that's engaged with all of this 4Ms improvement work. Dr. Supiao on the bottom left really was the inspiration, I think, locally, working with Dr. Fulmer back in the early days pre-pandemic, getting this stood up at Utah. And there is the beautiful Wasatch Front. So I'll encourage anyone to email me with questions, and thanks so much for your attention.
Hello, I'm Greg Alexander. I'm from Columbia University. I'm a registered nurse, and I'm going to talk a little bit about navigating the health information technology landscape in long-term care, how that fits with age-friendly care. We have one project that's funded by the National Institute of Aging where we're specifically developing an ontology with the age-friendly framework as a guide to help us understand how nurses and other providers could be able to communicate about age-friendly issues when they're communicating about patients. And that is an ongoing study, actually, that will end this year. But it's based on tens of thousands of text messages that nurse practitioners actually exchanged information with other providers in nursing homes across the Midwest when they were caring for dementia patients. So my work is really about data exchange, understanding how to utilize ontologies or words and language to get to better outcomes of care. As a registered nurse, I was always given technology at the bedside, and that people would say, this will make your job easier. And I sometimes experienced that and sometimes not. And so when I became a researcher and studied this long-term care area, that was always my goal, is to look at technology and how to improve quality. So I have no conflicts. I'm going to start really simply by showing this model of value-based care. We're really being driven toward value-based care. If you've been around the last couple of days, really the conversation that we've been hearing about from CMS is value-based care, that is super important, and this little ring of information around this value-based care sort of model, if you look at those, that's been discussed as well throughout this entire conference. Data interoperability is an area that I really focus on. I try to understand where long-term care settings are in their digital adoption journey and what their hit maturity is. And then we've done some cost analysis as well as some risk identification and transfer management and data exchange to help us understand how they do this, if they do it at all, and what the gaps are in relationship to their digital adoption journey, because not every nursing home is like another nursing home. They're all very different. But in order to do this sort of value-based care and to reach a value-based care system by 2030, it requires a mature health information technology system. And so for many years, I've been measuring health information technology maturity called digital maturity. And this all arose after meaningful use occurred. Many of you may remember meaningful use, there was a lot of legislation and adoption of rules and regulations to help hospitals and ambulatory care develop IT systems and incentivizing them to adopt them. Nursing homes and other long-term care settings were left out of that. Well, right at the beginning of my career, really, in this as a researcher, that took place, and I was involved in meaningful use. So I used that as a guide too to sort of help me understand where nursing homes are. And this is the model that I utilize. So what I'm interested in is looking at how technology is used, what the IT capabilities are, how much it's used, the extent of use, because oftentimes people will say, I have a certain capability, but we don't have that turned on, so we don't really utilize it. And then there's also the integration piece. So if they have the capability, they use it, is it well integrated so that it can become interoperable, so data can be exchanged? And in nursing homes, because they're so fragmented a little bit in their care, the services they provide the technology systems have historically been sort of fragmented. So, for example, in resident care, that's where nursing, PT/OT, all of those important areas are sort of interdisciplinary, providing interdisciplinary documentation to help them document things like age-friendly items that are important for patients. Clinical support is lab, pharmacy, and radiology. Well, most nursing homes don't have those inside their facilities, so they're contracting, they're trying to adopt technology that's not really integrated with other systems in the resident care, as well as the administrative activities. They also don't have IT departments. So if you think about the administrative point of view, they're oftentimes contracted with people that provide that service, or they have a corporate organization that has IT, maybe even states away from where the home is. So, but the local person that's usually the administrator of the IT system is usually somebody that's not trained to manage an IT system. It's usually somebody that is really good with an iPhone, for example. And now they're managing some IT systems, and that happens, and they learn sort of on the job. And so we combine those into 9 dimensions and domains. And what we really do is we look at sort of the journey over time of how people adopt. Right now, AI is really new. You've probably heard about it. It's something that people are talking about, but it's relatively new in the last 2 to 4 years. AI has been around a long time, but it's becoming more embedded in the clinical space and used in ways that it never has been before. So how is that new sort of technology impacting care delivery, and how is it being implemented? And we look across different systems to see how people are using it, and there's no real good evidence on how it should be implemented, especially in long-term care. So what do we do about that, and how can we reach this level where there's a high performance over time and meet the goals of people in the settings where this is being implemented? Another thing that I developed as a way of sort of understanding the journey of nursing home technology. And this came out of the meaningful use work that I did a long time ago with a lot of people. But there was always meaningful use stages for acute and hospitals and ambulatory care, but not long-term care. So I developed a maturity stage model, and this particular model goes from stage 0 to stage 6. Stage 0 to stage 3 on the left-hand side is for recognizes different stages of adoption based on a person completing a survey and telling us what kinds of technology they have in place, whether they have a team to manage technology issues or other things like that, whether they have governance. And the interesting sort of lay of the land in relationship to this maturity model is stage 3 to stage 4, there's a big difference. Anything from stage 3 and below, or from stage 0 to stage 3, that's all internal connectivity. So nursing homes that have that stage 3 or below do not really have the capability to exchange data outside their system. They may exchange data inside, but not really outside. Any home that is a stage 4 and above has the ability to exchange data. They have the ability to oftentimes to allow residents to be able to enter data from different types of devices, or even be able to access a laptop to be able to enter data about what they want in their lives, so what matters to them. And so it's resident driven, and oftentimes in clinical analytics are utilized in ways that they're not used in those lower stage models. And these become very important when you start looking at lower digital maturity facilities versus high digital maturity facilities. We found many outcomes and quality measures that are impacted by this. These are, sorry for the density of this slide, but I did work with the Moving Forward Coalition, and we did a round of Delphi methods where we got input from almost 20 experts on what would be the most important key areas to measure for digital maturity in a value-based care system. And these are the sort of 4 domains. The colored areas are the sort of 4 domains or content areas: resident management and technology used in any form of resident management, nursing care, as well as clinical support like lab pharmacy and radiology, which you can see there, and whether they have the capability, whether it's used, whether it's bidirectional or not, and administrative content areas. And then if you go over to the right, you see the numbers associated with each of those rows, and those numbers represent the items within the survey that we use to measure that area. So it's a very dense and comprehensive survey with 20 content areas and 142 items. But when you finish that survey, you know pretty much what the capabilities are. The interesting thing about this is when you measure it over time, I've used this survey, and I'm in my ninth year of national studies, and I'll show you some data about that. But the interesting thing about this is that over time, nursing homes may lose technology. About we have about over 2,000 nursing homes in our studies cumulatively, and about 30% of them will lose technology over the course of a year. In other words, they'll abandon it. They may be at 100% adoption, and the next year be a zero, right back on paper. And you can imagine what that might do to staff, what it might do for patients, and what it might do to quality of care. So it's very specific. This is an illustration of the quality measures that we've had in our digital maturity assessments over 7 years. And you see that there's 7 bars. Each bar represents a different year, and each section of bar represents a different part of the digital maturity assessment. So there's resident care capabilities, resident care extended use, and resident care integration, and that's the same for clinical support and administrative activities. And you'll see early on when we began to measure this, clinical support was really one of the areas that was the lowest. There was hardly any technology really available in those spaces, and if they weren't used a lot, and they weren't integrated very well with the rest of the information system. So if you're thinking about adopting the age-friendly measure in a long-term care setting, you're going to be challenged to measure probably the data that goes along with that, because it's getting better, but it's not optimal yet, and especially when there's so much variation between facilities. One of the things that's interesting about our measures is if you look between the sort of middle yellow column and the blue column, that represents the period of time when COVID occurred. And, the policies around the use of telehealth changed drastically, especially in long-term care. They were allowing any sort of technology to be used for telehealth. And we found that pre and post policy implementation, nursing homes were 12 times more likely to use technology, but they really didn't have a good evidence base for how to use it. It wasn't integrated into their documentation systems. And so there are many issues with how technology is being adopted in long-term care and how it's being sustained, and that we still have to address, I think, to really meet the value-based care goals. And that is what the Moving Forward Coalition is really about, and that is important for age-friendly care as well. So thank you. I'm going to stop there, and I'm going to turn it over to Alice Bonner, who's going to talk about moving forward.
All right, I have nothing to disclose, and I'm your last speaker, and I don't have any slides. And I talk fast, which is right now a good thing. So in 5 minutes, I'm going to try to summarize what you just heard from all these wonderful speakers. And I'll just start by saying a couple of people have referenced the Moving Forward Nursing Home Quality Coalition. We were established back in 2022 in response to the NASEM report called The National Imperative to Improve Nursing Home Quality. I imagine most people in this room have read the report. We took 600 pages of recommendations. We had committees. Greg Alexander co-led one of them. We established action plans, wrote them, and we're now testing and implementing them. And so I chair that group, and then I'm also on the age-friendly team at IHI. So I don't have an age-friendly name in my title, but I am on the team. Just back to moving forward, so our policy director, Jennifer Baker, is here. She's sitting right next to Marcus, and if you have questions about our group, either one of us would be happy to answer them. So again, as you're going back to your practice settings after this wonderful 2-day conference, I'm sure you'll be thinking about this, but what resonated most with you? Maybe it was something that we talked about here today. Maybe it was something you heard yesterday. What didn't you hear that you thought people were going to talk about that maybe you think is really important and you wish some of us had talked about it? I know we hear a lot. We've had a lot of presentations during this conference about things that are research, things that are tested in sort of the lab setting or an academic setting. But you also heard today about great implementation in Utah, in New York, and other places. So, hopefully you've heard some examples of real-world, actual implementation that's working, and you've got contacts and you've done networking with people who can talk to you more about it, which we've heard. We know, everybody in this room knows, there's challenges out there, right? There's staffing challenges, there's uncertainty in the world, those are a given. But that's not going to stop us, all of us, from making change and new activities that we're going to do every day. But that's not something any of us can do as individuals. We do this through teams, and you heard about this already, about some of the key themes during this conference have been about building the workforce and addressing workforce challenges. Specifically, again, I did a lot of clinical work in nursing homes. 500,000 certified nursing assistants work in nursing homes in the United States. They make very low wages. A lot of them are on Medicaid, about half of them. They're raising kids, single parents. Some of them are experiencing homelessness. This is a dire situation, and we have to change it now. We are past out of time. So again, good things about interprofessional teams, needs we have in terms of workforce. So workforce is one theme. You've been hearing about interoperability. You just heard about from Dr. Alexander. There are systems that, if we implemented them now, would absolutely change the dynamic in nursing homes, and they're there. So what's stopping us? What do we need to do to be able to implement those systems now? It's going to be worth the investment. And in terms of introducing new healthcare policies or promoting person-centered care, 3 key elements that I think you heard about from probably everybody who spoke at this conference. Number 1, implementation science. So implementation science, we have to understand it better. We have to get out there and really be aware of what we need to do in the real world with implementation. Documentation, you heard about that from Greg, and communication. You heard about, how do we communicate? What's the language that we use? Getting beyond ageist terminology, which is still out there, and making sure everyone on the healthcare team really understands and knows what's in their care plan. So everybody from the older adult at the center of it to CNAs who are out on the floors or other direct care workers. So again, I know this has been a very rapid fire set of information, but hopefully you've heard great information from the other speakers today, and that you'll take back with you that a key theme across all of the conference sessions has been a broad, diverse, interprofessional team to do this age-friendly health systems work, which, as Ronnie started us with, is a moral imperative. So thank you. Lenise, back to you.
Well, thank you again to all the wonderful speakers, and this really was a wonderful presentation. I want you all to think about everything that you've heard about, how you can really institute change and use age-friendly healthcare as a structure in order to implement some of the priorities that we've been speaking about throughout this conference for CMS. And if you have any questions, feel free to email me or any of the presenters. My email is my whole name, Lenise.CummingsVaughn, it goes on forever, at cms.hhs.gov. And I appreciate everybody coming, and I hope you go across the bridge to the closing presentation. Thank you.